Hello, welcome. My name is Christina Booth. I am one of our nurse practitioners here at the Center for Colorectal and Pelvic Reconstruction at Nationwide Children's Hospital. I'm joined here today with Dr. Daniel DeGiusta, one of our pediatric urologists and the Center for Colorectal and Pelvic Reconstruction urological director. Welcome, Dr. DeGiusta.
Thank you, Christina. In fact, we're all a team here. We participate in the colorectal department center as a team of 3 urologists that combine our expertise at the center, 3 colorectal surgeons and 2 gynecologists. And we'd like to think that everybody plays this very specific role and very important role in the care of these patients.
Thank you. So today we're going to talk a lot more about the urological care of these patients. So Daniel, tell us, why would a patient coming to a colorectal center see a pediatric urologist?
Well, that comes from the part of our research that we have developed over the years in these patients that notice that a lot of these patients, while they have a significant anorectal malformation problem, comes together a good amount of urological issues. And many of those patients have significant congenital renal abnormalities as well as bladder abnormalities that will require long-term life care. And the pediatric urologist is going to be your best friend in order to make sure that those issues are not only addressed but taken care of in order to protect the long-term function of those kidneys, which will be required for your entire life.
One of the common questions that we get asked is, when does the urology team actually get involved with our Center for Colorectal and Pelvic Reconstruction patients? And really the simple answer to that is that we actually see all patients before they even get here. We are involved with their new intake process that is completed by our colorectal nursing team. And the urology team takes a look at those new intakes and reviews each patient and gives recommendations from the urological aspect of care. And then those patients are followed up in clinic and we see them routinely. We know that patients with anorectal malformation can have, these urinary anomalies like Daniel had just mentioned. And so it's really important for us to highlight those patients. We kind of consider it a spectrum. Some patients are considered more low risk and don't have a lot of urinary issues. Other patients have significant urological issues. And so really for the urology team, it's important for us to identify what patients have more of those significant urological complaints or issues and for us to get involved in caring for those patients. Daniel, describe some of the most common urological diagnoses that we actually see in the anorectal malformation patient population.
Indeed, right at birth, we try to see those patients and get some information on that, starting with a simple renal ultrasound is the easiest way. And we can see that a good percentage of those patients will have a renal abnormalities, and one of the most common is vascular reflux, where urine goes back up into their kidneys from their bladder. There's also absent kidneys and anomalies of duplicated kidneys. But most important is abnormalities that could lead to loss of renal function that need to be followed closely and potentially corrected early on in order to preserve as much function as possible, as our goal is always to protect the renal function. I know a lot of the parents comes to us and they are concerned, my kid has an anorectal malformation that could affect the bladder, and most parents are of course concerned for the long term, and the immediate concern is often continence, both for stool and for urine. We certainly can now provide them with a little bit of a tool in order to help them identify the patients that will have normal continence and the patients that may need a little bit help from that standpoint and may need surgery for that. But most importantly, we also can help identify those patients that need to be watched closely for the renal function, which is sometimes a silent problem that if you're not looking for it, you might miss. And doing surgery is great. You can correct a lot of the problems that the parents are concerned, but if you don't address the renal function, that can be a long-term effect on the kids and could shorten the lifespan of some of those kids if they lose kidney function. And that's where having a pediatric urology interested in making sure that the renal function is preserved is so important part of the team of taking care of the anorectal malformation patient.
So you just mentioned several different diagnoses, and we do a lot of urological testing to kind of help us pick up on some of these diagnoses that we find. So some of the most common tests that we order in the urology world include things like a renal bladder ultrasound. So that's basically a test where we put slimy jelly on the belly, take some pictures of what the kidneys look like, what the bladder looks like, A really important part of this is also checking to see if someone's potty trained, how well do they empty their bladder. So we actually check what's called a post-void residual, have the patient pee during the study and check and see how well, again, they empty that bladder. Other tests that we do include things like a VCUG or voiding cystourethrogram. That's an anatomy study that just helps us identify what's going on, helps us to identify that vesicoureteral reflux that Dr. DeGiusta had mentioned. And basically what we're looking at that test is a catheter study. We fill the bladder up with dire contrast and take some pictures and imaging to let us know what's going on from that standpoint. Other testing include things like urodynamics, which is a bladder function test. It's also a catheter study where we fill the bladder up and we just see what's going on with the bladder and learn more about how is the bladder functioning or how is it working. Some additional things that we might get would be things like a renal scan or lab work or even a cystoscopy. But those are kind of things that are tailored based on the individual patient and what we feel is necessary from the urological evaluation. Now, Daniel, tell me a little bit about what are the goals of the pediatric urologist in this patient population?
Well, the initial goal is to evaluate baseline renal function and see where they stand from that standpoint. And of course, overall, the goal after that would be to preserve function of the kidneys throughout their life. And the second goal is to provide the parents with a solid understanding of the future continence potential of the child. And luckily now we have the expertise to do so through a recent study that we performed showing that the famous ARM index plus a few other factors, including the type of ARM malformation, can predict the child ability to potty train for urine as well as for feces. So for stool. So thus we can use that to help the parent, to guide the parents through this process. It's a very difficult process when your child is born with ARM malformation, and there's a lot of questions. And hopefully we're helping answer some of those questions, help putting those parents at ease with some of that. And thus, evaluating some of those factors help us guide the parents to what future may hold, including the potential for surgeries that can correct some of the issues with continence and provide continence. But our goal, ultimately, is to get the child around potty training time dry for urine and as well clean for stool. And our part, of course, as a urologist, to get them dry for urine is the way we see most important.
You've mentioned urological surgery several times here in this talk. What are some of the most common urological surgeries that you do, and when and why are they done for a patient? Well,
I would say the most common surgery we do would be the cystoscopy. That's probably what you're going to get more commonly with us as your initial evaluation. And what it is done for is mainly to assess the anatomy and give us an idea of risks and what kind of procedures may be required. Then the next common procedure, as we often help the colorectal surgeons during the anorectal malformation surgeries to repair the urethra and make sure the urinary channel is at this top, it's as close to normal as possible in order to allow the patient to urinate and to get the urine out in a normal fashion. Following that, we can also provide surgeries for continence, where we would increase the resistance of the sphincter and help patients stay dry. And most of those surgeries have to be coupled with another way for the patient to drain their bladder, which is often something called a Mitrofanov, or a catheterizable channel, where the patients can pass a small catheter to empty their bladder that way. There are also surgeries to make the bladder a little bit bigger if the patients are having trouble with storing urine, and that can be done in conjunction with a lot of the operations that they require for the colorectal standpoint. Our goal is to try to minimize the number of procedures in order to get the child dry, clean, as well as in order to get the kidneys in a safe situation.
Wonderful. Very helpful information. Thank you for your time today, Daniel.
No problem.
Thank you.
Thank you.
If you'd like more information about the Center for Colorectal and Pelvic Reconstruction here at Nationwide Children's Hospital, please visit our website at www.nationwidechildrens.org/ccpr. Thank you.
Thank you.